Good afternoon, everyone. Welcome to the afternoon session and welcome to an update on herpes viruses in ophthalmology. I've often thought of myself as something of a herpes virus. I am ancient and I have DNA, and you can't cure me under any circumstances. But more importantly, herpes virus causes a host of ophthalmic diseases, a lot of which are very hard to treat. And Mailing Taikani, who is here somewhere, has put together a very nice symposium on herpes viruses for us. The first talk is going to be by Stephanie Watson. Stephanie is the head of the corneal unit at the Sydney Eye Hospital and head of corneal research group at the University of Sydney, and she's going to talk to us about simplex keratitis. Stephanie.
Thank you. Okay, so a nice after-lunch topic, herpes simplex keratitis. And so the herpes simplex is one of the herpes viruses. Here are the other herpes viruses. And the things with herpes viruses is that we actually have very high rates of having been infected in the past. So 9 out of 10 of the population have had a herpes virus, but in most people it remains latent. So now, how can herpes affect the cornea? Well, it can affect any layer of the cornea, and it can be classified either according to what layer of the cornea it affects, and then whether it's primary or secondary. And so you could have an epithelial keratitis, a stromal keratitis, endotheliitis, and keratouveitis. But it's also important to remember that herpetic keratitis can cause a neurotrophic keratopathy. And the neurotrophic keratopathy can be used as a way to help diagnose herpes simplex. Okay, so it's actually the most common virus acquired by humans. So if you look at IgG, it's 70% of us are positive before the age of 20 years. And then by 70 years, 95% of people have IgG to herpes simplex. But interestingly, only 1% of us will have a clinical infection with the virus. Now, there's two types, type 1 and type 2, which are antigenically related, and they can actually co-infect ganglion. But the one we see the most of is herpes simplex virus 1, which is above the waist, and herpes simplex 2 is below the waist. And so that's something reassuring to tell patients. Because when you have to tell a patient, look, they've got herpes simplex in the eye, some people find that diagnosis a little bit confronting because it can be an STD. But you can reassure them that it's commonly, that's usually herpes simplex 1. So how do we go about diagnosing a patient with herpes simplex keratitis? Well, as with any condition, we always have to begin with the history. And it's the history of the actual eye problem, but also a history looking at risk factors or clues that what you see might be herpes simplex. And the typical one we ask about is labial cold sores. But the other big clue is whether they've had a prior episode of herpetic keratitis or recurrent sort of corneal infections. And then on your examination, you're trying to figure out, look, well, what is the manifestation of the herpes virus infection? What part of the cornea is infected? And then in some cases you can move to investigations. And this is typically done if you've got the first presentation. So if you have a patient come in with the first presentation of query herpes simplex, then doing a PCR test is helpful because if the patient has a recurrence, they can then pass that information on to the ophthalmologist that's then seeing them. The other scenarios we may do testing in is if the case is atypical or complicated, and definitely in neonates. Investigations, look, viral culture is the gold standard, but it's not really in use clinically. And so the most common thing is PCR. And there we have a sensitivity of 70 to 100% and a specificity of 68 to 98%. But the overall positivity rate reported in some studies can be low at 27%. And this is because if you have an endotheliitis or keratouveitis, you're only really sampling the surface. And so your chance of getting active virus or virus present is lower. So that you'll get a higher result with epithelial herpes simplex. Now, if you consider primary infection, because one of the ways we try to diagnose herpes when we see a stromal case is to say, look, have you had an episode of herpes simplex before? And the patient may have only had a very mild case. It may have been a mild blepharitis even, or conjunctivitis, that they didn't even recognise or get treated for, so it can resolve, and that may have been their first presentation. But the most typical sign is our dendritic ulcer. You can check for preauricular lymph nodes to differentiate from adenoviral infection, and look closely at the epithelium. Now, a condition that can be confused with herpes simplex is acanthamoeba keratitis. And this sort of dendritic-looking lesion here in the epithelium is actually a pseudodendrite. It's actually acanthamoeba, and so it's perineuritis. So it's not actually a dendrite. But the interesting thing with acanthamoeba is that it can initially respond to antivirals. So if you see a lesion and you think it's herpes simplex, you start your treatment, there's some initial response but then gets worse, remember acanthamoeba. And the distinguishing feature on the examination is that the epithelium in acanthamoeba just looks disturbed. It looks sort of mottled, whereas with simplex, the dendrite is there, but the rest of the epithelium can look normal. Okay, so and now what about recurrent? So we've spoken about primary. What about recurrent disease? Well, this is typically a stromal keratitis, and it can be defined as ulcerating or non-ulcerating, and is typically associated with loss of vision, and that's because over time you get scarring, vascularization, lipid deposition, and recurrence can be common, and you can even get superinfection with a different strain of herpes simplex. And now, why does it happen? Well, there's some host genetic factors and susceptibility factors on the host in terms of their immune status. We don't really fully understand, but we know there's an increased risk if there's immunosuppression, such as with diabetes, HIV, or after organ transplants. Sometimes local factors can increase susceptibility to herpes simplex, and this includes topical medications, particularly steroids. I'll talk later about glaucoma therapies, surgery and trauma. And one of the settings where this can be a bit confusing is after a corneal graft, because herpes can occur in a patient that's never had herpes before after grafting, or the herpes may be reactivated. And if you're treating with topical steroids after your graft, because you're trying to avoid rejection, you may actually see herpes and it can confuse the picture. So immune stromal keratitis is stromal infiltration without necrosis and ulceration. And this is an antibody against viral antigen in the stroma from persistent infection. So there's some infection here, but it's basically an immune reaction. And you get neovascularization, lipid thinning, such as this case shown here. So necrotizing stromal keratitis is when you have stromal infection, but with ulceration. And here you do have viral infection again, but the difference is you get a very intense immune stromal inflammation. And it can sometimes follow other types of herpetic disease. And this has implications for treatment, which I'll discuss. Endotheliitis is most commonly disciform, which is circular, as you know, linear. Sometimes it can look like a graft rejection. And it can self-resolve in some cases, but it can also progress to stromal disease. Now, when we had a look at the Sydney Eye Hospital to see what prescribing patterns were occurring for herpes simplex keratitis, we found that only half of the treatments prescribed actually met the current recommendations at the time. Treatment for epithelial keratitis was most commonly done correctly, but there was a range of treatments for stromal disease, for endothelial disease, and also for prophylaxis. And so we went on to develop a herpes simplex treatment guide, which is what is available for anyone to use, and it specifies the recommended doses for starting treatment in an initial case, including steroid therapy and antivirals and renal adjustment. So this is what the guide says. So for epithelial herpes simplex, the guide was based on current evidence, and also a consensus panel of specialists, of corneal and uveitis specialists. And the reason we had the panel is because some of the evidence was derived from the HEAD studies, which were done a while ago and in a US context. So we wanted to make sure that these guidelines actually were able to be compatible with and reflected, what practice is happening in Australia. So you can use topical acyclovir 5 times a day for 2 days. There's bugs here. Hopefully no herpes. Or you can give Valtrex orally twice a day, 500 for 7 days. And you may give an oral drug if they're immunocompromised, if you're worried about them being able to use the ointments, or if they've had ocular toxicity. So topical acyclovir, particularly after 2 weeks, can get very toxic. And then it can be hard to tell, is like, is the herpes getting worse, or am I, causing more toxicity? Okay, stromal herpes simplex keratitis. And this is where distinguishing between ulceration and non-ulcerated disease is important, because there's variations in the treatment based on the pathophysiology. So if you have no ulcer, your Valtrex is at a prophylactic dose because you don't have that much virus, and you're giving prednisolone forte, say 4 to 6 times a day, and that can be tapered over 10 weeks with your antiviral. If you've got an ulcer, then you really need to increase the Valtrex because the viral replication is causing this persistent stromal inflammation. And then you can begin your Pred Forte and slowly taper it as the disease comes under control, with the aim in all these cases of reducing valcyclovir to a prophylactic dose after 7 to 10 days. And you maintain this for as long as you're giving frequent topical steroids. And in the head studies, they actually continued treatment for 10 weeks. So sometimes it can take a while to completely treat the disease. And for stromal HSK, you do need to give steroids as part of your treatment. We found with our data that in a lot of cases, steroids weren't given, and this led to a more prolonged course of the treatment. Endothelial disease. The evidence in the literature on treating endothelial disease is very sparse. So we looked at what was there and recommended valcyclovir 1 gram 3 times a day for 7 days, plus prednisolone forte around 4 to 6 times a day, and then tapered over about 10 weeks. And again, reducing the Valtrex to prophylaxis after about 7 to 10 days, or for as long as you've got frequent steroids. Now, prophylaxis. When should we give prophylaxis? Well, my general rule is that they have to have had about 3 to 4 episodes of herpes simplex within a year, or a case where it might be an only eye. But it's a lot of tablets to take every day if you're not having that many episodes. So you may give it, particularly after ocular surgery, including particularly grafting. I don't give it routinely in cataract surgery unless they've had a lot of frequent episodes. If they have a vague history of having herpes simplex, 10, 20 years ago, I generally don't give prophylaxis, but I watch them very closely post-op. But anyone with a recent history of active herpetic disease, you can prophylact, also during immunosuppressive therapy. And look, most practically, this is done with Valtrex 1 tablet a day. There used to be a preference for acyclovir tablets, but you have to give twice as much. And that's because Valtrex used to be much more expensive than acyclovir, but it's come off patent and it's cheaper. So when to give systemic antivirals? Well, for stromal disease, for skin involvement, if you've got coexistent systemic disease, a patient that's going to be non-compliant, and someone that's immunocompromised. Now, the other thing to remember in your elderly patients, particularly, is that if they've got renal disease, you may need to lower the dose. Unfortunately, I've seen patients go into renal failure on antivirals that have been given at too high a dose. And so this is the adjustments that you can make for renal disease. What about pregnancy? Well, most of the studies and data has been on acyclovir. So even though Valtrex and valcyclovir is probably similar, there's just not the published data. So acyclovir is probably preferred. But with Valtrex, it could be used, say, from 36 weeks. And they're basically category B3. Now, for children, bilateral disease can occur in up to 20%, so that's quite a lot. And often bilateral HSK is misdiagnosed or confused with staph blepharokeratoconjunctivitis, and also the other way around. So keep both things in mind when you have a patient with blepharitis or lid disease and corneal changes. It can be quite recurrent, and if they get scarring, they can end up with amblyopia. So it can also be difficult to do the examination, so they won't cooperate. If you really need to and it's a young child, then please do an EUA. And the amblyopia can often be impossible to manage because it's an irregular astigmatism. So, but the current guidelines, and again because of the fact that the studies have been done with acyclovir, is that acyclovir is the drug of choice. But Valtrex you can be given after about 12 years of age. If it's epithelial, you can just continue with topical acyclovir, and you continue that for about 14 days, or at least 3 days after healing, whichever's shorter. So to 12 years, if they're very young, neonate, always get advice from the infectious diseases physician. And at 3 months to 12 years, you can get oral acyclovir in a liquid, and the dose is dependent on their weight. And you will need to give prednisolone Fort eye drops. Children that are 12 to 18 years, again, it depends on weight. Generally, by the time they get about 15, you can generally give them the adult dose. And so that's 500 milligrams twice a day for 5 days, plus prednisolone Fort as needed, just as a guide. The other circumstance you might see bilateral disease in is in atopic disease in younger patients, and it can be severe. With cataract surgery, as I was saying before, consider prophylaxis. Oral's better than topical because it's going to act on the ganglion. And if you've got a really severe case, you may consider giving non-steroidals rather than steroids. But if they've got neurotrophic keratitis, watch out. Contact lens wear, there is an increased risk of herpes simplex, and an increased risk of, recurrence of herpes simplex if a patient with contact lenses wears contact lenses. And so you have to warn any patient that's had herpes that wants to wear contact lenses that they may have a recurrence. Surgery, look, it's a contraindication after refractive surgery due to corneal melting. And with PK, as I was saying before, there's an increased rate of recurrence, and that can be up to 30%, increased rejection, increased risk of new herpes simplex, so 14 times that of the population. And that may be because the donor tissue may contain the virus, or we may reactivate it with our topical steroid regime. And most of us would probably prophylact for the first year. But probably the lesson, though, is really don't do a graft in HSK unless you have to, because at 5 years, 50% of them are in the bin. Topical acyclovir is absorbed through the epithelium and superficial ocular tissues, and so you do get some concentrations in the aqueous humor and low levels in blood. If you're giving topical, you don't really need to give systemic. And the only reason you'll do this is children if you're worried about absorption. And systemic is generally better for prophylaxis than topical because of the latent HSV in the ganglion. And just acyclovir and valcyclovir, the bioavailability is 3 to 5 times greater with valcyclovir compared to acyclovir, and the equivalent dose is there. That Valtrex twice a day is the same as acyclovir 5 times a day. Ganciclovir gel is similar to acyclovir, and it has been used for epithelial keratitis. We have less information on its long-term role, particularly for prophylaxis. We've produced some educational videos on herpes simplex keratitis, both featuring this guideline and educating residents and registrars about the different types of herpes simplex. So just finally, do glaucoma medications trigger herpes simplex keratitis? There's been a recent study looking at health databases from a Canadian province, and this was a retrospective study looking at multiple types of glaucoma agents and the dispensation of antivirals, and they found no increased risk of herpes simplex or herpes zoster keratitis with any of the 4 glaucoma medications used. Now, it's not a perfect study, but some data, so this data is suggesting that it doesn't actually matter. There's also been case reports that there is a potential temporal association between herpes disease and the COVID-19 vaccine. Again, looking at the literature, these are mainly sort of case reports. So, particularly if they've had aggressive and recurrent herpes simplex, you may want to consider prophylaxis if they're having their COVID vaccine, if anyone's going to have them anymore. So, lastly, herpes simplex can affect all layers. Recurrent disease can give you visual loss. The management often is topical acyclovir 5 times daily for primary disease, and recurrent disease, you typically need steroids. For prophylaxis, it's fairly standard for most conditions at 500 milligrams daily. Thank you, and these are the guidelines. Oh, sorry, just should thank the other team, the rest of the team that worked on these guidelines: Maria Carrera-Ragas, Dana Robai, Shameen Samrik Rama, Eve Kidron, Richmond Science, and Professor McCloskey. Thank you.
Thank you very much, Stephanie, for that stellar overview. All of the talks are on slightly different topics, and I think we will have the questions at the end of each talk. I'll be looking at the app if you want me to curate your questions for you during the app, or if you want to come to the microphone, you can come to the microphone. So, does anyone have any questions? So the question is about herpes simplex immunisation, Stephanie.
Oh, you mean other types of immunisations? Because there's no... immunisation for herpes simplex. I don't know that there's enough, I don't know that it exists or there's clinical data on it. Zoster immunisation is generally recommended. Yeah.
Rachel. Yeah.
How much resistance do you think there is to acyclovir? When we're getting a patient which we've diagnosed clinically and think this is HSV keratitis, we've started treatment with topical acyclovir and it's not working. Should I be rethinking my diagnosis, or should I be switching them to ganciclovir, or should I just box on?
Yeah, no, we've had this conversation on a number of occasions with our virology experts at our hospital, and the view from the virologists is that the resistance rate is very low, unless, say, you've somebody that's been on antiviral prophylaxis for a long time. So initially the first thing is to check compliance. Make sure they're getting the drugs. But sometimes, yes, we do, go through and change the medication. But in theory, the resistance rate should be low. So the other important point is to make sure you've got the right diagnosis. I often see neurotrophic keratitis treated with topical acyclovir, and the epithelium will just start to fall off and look worse. So bear in mind that can be another manifestation of herpes simplex.
So the question is...
yeah. So, generally for, it's judged on the patient, but generally sort of 4 to 6 times a day. Yeah. Oh, the question was, I was saying in my talk about the use of frequent topical steroids. How often would you give it? And it might be, 4 to 6 times a day. But, sometimes it's going to be adjusted to the amount of inflammation that you see on the eye. But, say 4 times might be a good starting point. If it's still inflamed, you could go up if you've got your antiviral on board.
That's all. Thank you very much. So our next speaker is Dr. Priya Somalia, formerly of the Eye Hospital, but now a consultant at Christchurch Hospital and at the University of Otago. She's going to talk to us about zoster vaccine and herpes. And again, if you have any questions and you wish to use the app, I will look at the app during the talk.
Cool, thank you. So I'm just going to be talking about the effects of the zoster vaccination on herpetic eye disease, mainly to do with uveitis. So in terms of the efforts to manage herpes zoster ophthalmicus, it can be broken down into prevention of disease, which is where the vaccinations come into play, treatment of active infection, and treatment of post-infectious inflammatory events. So in terms of varicella vaccines, Varivax is a live attenuated vaccine which is intended as a primary vaccine for chickenpox. It's on the immunisation schedule for children and it's given in 2 divided doses. Zostavax was approved in 2006 for the secondary prevention of reactivation varicella, or prevention of herpes zoster. It's a live attenuated vaccine and it's given as a single injection. Shingrix was a recombinant subunit vaccination, which was approved in 2017 for adults 50 and over, and it's administered as a 2-dose schedule. In terms of Varavax, so this is the live attenuated vaccine that was available in 2006. It's based on studies. So the shingles prevention study was a large double-blind placebo-controlled trial, which showed that this vaccine reduced the development of shingles by around 50%. It lowers the chances of developing severe disease and also the potential for post-herpetic neuralgia. And that study was done on people who did not previously have shingles. There was a smaller follow-up study using 420 adults, which did previously have shingles 3 to 5 years prior to Zostavax, and it showed that it was still effective for reducing the recurrence, with only one unspecified eye complication, but there wasn't any sub-analysis for herpes zoster ophthalmicus. More recently, Shingrix has come into play in 2017. So this is a recombinant vaccine. So it comprises of this, I actually have my pointer there, but there's a recombinant VZV glycoprotein E component and an adjuvant system. And the adjuvant system is composed of 2 immune stimulants. One's a toll-like receptor 4 agonist, and the other is a saponin-derived molecule. So the adjuvant system induces the innate immune system cell response, which enhances the glycoprotein E antigen presentation to T cells and increased production of antibodies and CD4 positive T cells specific to this VZV glycoprotein E. So ZO50 and ZO70 were the large randomized placebo-controlled phase 3 trials looking at Shingrix. The overall efficacy of the vaccine in both studies was around 97.2%, and it had sustained benefit over at least 8 years following vaccination. In comparison for the two, so Zostavax and Shingrix, because of the reduced effectiveness over time, the decreased effectivity in older subjects, and its contraindication for use in immune-suppressed patients, Zostavax is no longer the preferred vaccination. So Zostavax is no longer available in the United States as of November 2020, and it's been discontinued from the New Zealand funded market in August 2022. The differences in the efficacy between the two vaccines are more pronounced in older age. So it reduced disease by 60% in those between 60 and 69 years. That reduced to 40% at 70 to 79 years, and that efficacy dropped down to 18% over the age of 80. And theoretically, with the viral subunit in the recombinant vaccine, so the Shingrix vaccine, that viral subunit is thought to reduce the potential for reactivation. So in terms of complications, so varicella activation and reactivation after any form of the Zostavax vaccinations are rare. So the shingles prevention study for Zostavax, only 17 out of over 19,000 patients who received the live attenuated vaccine reported a varicella-like rash, and 5 of those tested for wild-type varicella rather than the Ocular virus strand, which was in the vaccine. So from the vaccine adverse events reporting system, post-immunisation herpes zoster occurred in 6.1 cases per 100,000 patients with Shingrix and 12.7 cases per 100,000 following the Zostavax vaccination. So there have been uncommon instances of patients who developed herpes zoster either as a first episode or recurrence following Zostavax vaccination. And there have been several small reports on uveitis, so anterior uveitis, interstitial keratitis, sclerokeratitis following the Zostavax vaccination. There have been a handful of case reports of acute retinal necrosis following Zostavax, and these have predominantly been in immune-suppressed patients or relatively immune-suppressed. So the first case there was a patient who had a history of diabetes who developed 6 days after the vaccine. The second case was someone who was immune suppressed with mycophenolate, tacrolimus, and prednisone for a renal cell transplant, who developed ARN 2 months after the Zostavax vaccination. And the third case was someone who was immune suppressed with methotrexate for rheumatoid arthritis and also had diabetes, who developed ARN 6 weeks after the Zostavax vaccination. And the third case actually had genotype PCR for the type of viral strain that caused ARN, and it was actually confirmed to be the Ocular virus vaccine strain that had caused the third case's ARN. There's been one case report of an immune-competent patient who developed ARN 3 months after the Zostavax vaccination, but in that case there was no genotyping done for the type of for the virus that caused ARN. In terms of shingles, the ZOE trial showed that uveitis was recorded in 1 in 14,645 subjects receiving the Shingrix virus. Post-licensure surveillance with the vaccine adverse events reporting system showed that eye inflammatory effects occurred in 0.4 per 100,000 doses, with some of these being related to uveitis. So there have been reports of uveitis occurring after the Shingrix virus, predominantly with keratitis, keratouveitis, and keratoconjunctivitis and anterior uveitis. And these were in people who already had a pre-existing inflammatory eye disease. There's been one case of reactivation of multifocal choroiditis following the Shingrix virus, and one case of ARN, which was reported in a subject who was relatively immune suppressed. So they had a history of multiple myeloma, an autologous stem cell transplant, and were immune suppressed. 2 months after the Shingrix virus, they developed ARN, but again, with genotyping that was done in that case, it was found that it was wild-type virus, not related to the vaccine strain. So it was more likely representative of vaccine failure rather than causative. And there's been one case loosely associated of sarcoid being induced by the Shingrix virus, Shingrix vaccine. In terms of the mechanisms by which this happens, it's not known, but there's lots of different theories. In terms of the Zostavax live attenuated vaccine, it's probably due to direct inoculation of the attenuated but still live virus in the vaccine. The Shingrix is not a live virus, so it doesn't contain any viral particle. So in terms of uveitis caused by Shingrix, it's probably related to adjuvants within the viral vaccine. And this is something called Schoenfeld syndrome, where you get an auto-inflammatory reaction to vaccine adjuvants. But they usually also get constitutional symptoms with the syndrome, including arthralgias, myalgias, and chronic fatigue. And in all the case reports in the literature with Shingrix vaccine, they had none of the constitutional symptoms. It was all just localized ocular symptoms. And again, usually with this syndrome, it's thought to be aluminium salts that cause the inflammatory response. Shingrix hasn't been listed to have aluminium salts, but it does have a lipid component, which is thought to be the culprit adjuvant, which can cause this immune inflammation. There's also another thought that it's the generalized upregulation of the immune system with the vaccine that causes the inflammation. And also, again, potentially lack of efficacy of the virus, so of the vaccine, so failure of the vaccine to actually cause any protection. In terms of keratitis as well, there has been reports of viral DNA actually present and detected within the corneal tissue up to 8 years following herpes zoster ophthalmicus. So one potential cause of keratitis with shingles, with the Shingrix virus, Shingrix vaccine, is that the upregulated immune system actually activates residual viral DNA within the corneal tissue to cause the keratitis. The other thing to think about is the ideal length of time to wait from uveitis to actually giving someone a vaccination if they're interested in the Shingrix vaccine. There's no established length of time between zoster and the vaccine that has been established. Most people wait for at least 12 months. There has been a study which shows that the immune response to VZV following lasts for about 3 years and is similar for 3 years following the Zostavax vaccine and an episode of Zoster. So potentially waiting for 3 years may be reasonable as well. In general, for the CDC guidelines related to people who have autoimmune or inflammatory conditions, the CDC recommends that the vaccine should optimally occur in the setting of well-controlled autoimmune or inflammatory disease, so not given during an acute disease or during a flare. Ideally, if they can be given the vaccine prior to immune suppressive medication being started, but if that's not an option, then the Shingrix vaccine should be administered when immune suppression is anticipated to be low. For those patients who receive anti-B cell therapy, so that's things like rituximab, they should get a dose of the Shingrix approximately 4 weeks prior to their next infusion date. And for those taking prophylactic antiviral medications, the vaccine should be given ideally 2 months prior to the discontinuation of antiviral treatment. In terms of the New Zealand Ministry of Health guidelines, it recommends giving Shingrix at least 12 months after an episode of shingles has resolved completely. And if someone was interested in getting a Shingrix after they've had Zostavax, to wait at least 12 months as well. So uveitis is a common complication of herpes zoster ophthalmicus. Approximately half of people who develop acute herpes zoster ophthalmicus will develop uveitis, and it's an important cause of severe and moderate vision loss. The zoster vaccinations are efficacious in terms of reducing the incidence of herpes zoster ophthalmicus, and the associated visual morbidity, as well as post-herpetic neuralgia. But it's important just to counsel patients about the potential expected local and systemic reactogenicity as well. Thank you.
Maria, that was a great overview of an important subject. So until the vaccination, the incidence of zoster and zoster ophthalmicus was climbing steadily in our community. But certainly in Australia, the research that we've done shows it's roughly halved since the incidence of vaccination. But there's a lot of questions have come through. I think a few of these questions you've answered. So just to reinforce, someone's asked, when after an episode of zoster should they have their vaccine?
Yeah, so ideally wait for at least 12 months, and it's during a period where they're completely quiet without any flares, and if they're on prophylaxis, again, continuing the prophylactic treatment for 2 months after.
And for uninvolved patients, how often should we be recommending zoster boosters?
So the Shingrix vaccines recommended for those 50 and over as 2 doses, and it lasts at least 8 years. So I'm not sure about the boosters.
Now, this is an important question which does not involve me or anyone in the audience over about the age of 30. But for those in the population who've never had chickenpox but have had a live attenuated vaccine in childhood, which in Australia is those under the age of about 30, is there any risk, do they get any latency? Is there any risk of them getting zoster ophthalmicus from the vaccine itself, like vaccine-related zoster ophthalmicus? That's an excellent question, isn't it?
I think there have been theories in terms of that being one of the reasons why there's an increasing incidence of herpes zoster, but there are other studies which have shown that that's not an actual, doesn't have an impact in terms of the increasing rates of herpes zoster. And there's no, from the CDC guidelines, there's no need to test someone in terms of their serology for chickenpox or having had the chickenpox vaccine before being able to have Shingrix.
So for those of you in the population, which there's going to be an increasing number, who've never had chickenpox and have had the chickenpox vaccine, do they get re-immunised as they get older? That's the question. Should they have a vaccine, which then presumably a vaccine against the original chickenpox, not against shingles, when they're older? Is there, I don't know. Does anyone know? Rachel, do you know, is there a recommendation? Yeah, okay. Okay. Yeah. Okay. And the last question is about, so the question is, so there's a large cohort in our population who are basically those under the age of 30 who've never had chickenpox and have been vaccinated in childhood with the live vaccine. The original, your kids, Benny, got a zoster vaccine, that's a live vaccine, what do we do with them? Do they need to be boosted?
So I was just saying that, when you're a child and you get chickenpox, usually that's one and done. You don't then get chickenpox again, as an adult. And we obviously do not have 50 years of data, for our chickenpox vaccination, but the presumption is that it's going to last. And so you're not going to need to have your zoster vaccine, you're not going to need to have your chickenpox revaccination. But I think, this is in such early days with the vaccine, and what the titers are going to do, that we're just going to have to watch them and see.
And one last question, Priya. Someone has asked here about Ramsay Hunt. Is there any specific information about Ramsay Hunt? Has the incidence of that being reduced? Are we getting Ramsay Hunt reactivations from the vaccine?
I don't think I can answer that one, actually. I don't look specifically at Ramsay Hunt, yeah.
And then someone else said they want this session live streamed. And I finally got a whole lot of questions for you, Stephanie, which we will address later. Sorry. Okay. Thank you very much, Priya. Our next speaker is Dr. Rachel Niederer, who's from Auckland Hospital. She's a senior lecturer at the University of Auckland, and she's going to talk to us about herpes zoster ophthalmicus.
Okay, great, thank you. So this is a topic that's very dear to me, so I'm really pleased to get the opportunity to speak here on it today, so thank you for inviting me. So just to briefly talk about herpes zoster ophthalmicus, as we know, this is a member of the herpes virus family. Primary varicella is going to give you chickenpox, and then herpes zoster ophthalmicus is reactivation of that latent varicella zoster virus in the V1 distribution. We can also get zoster sine hepatica, which is reactivation of latent zoster virus in the absence of typical shingles rash diagnosed via PCR, and of course acute retinal necrosis. And chickenpox I'm only going to mention very briefly, but the summary with this is that ocular complications of chickenpox are exceptionally rare. These are not patients we need to see in our general practice unless they're coming in with loss of vision or photophobia or cranial nerve problems, pupil problems. And we did a study looking at this within Auckland and estimated that the risk of having an ocular problem that needed treatment associated with chickenpox was 1 in 27,000 cases. In terms of zoster sine hepatica, these patients have no history of that typical shingles rash. They get a chronic anterior uveitis with marked iris atrophy, and they may get high pressures, and you can diagnose them via PCR. And there's probably more of this than we're actually recognising. So zoster, as we've talked about, this is the reactivation, and a third of people get shingles in their lifetime, and of these, about 10 to 20% are going to be herpes zoster ophthalmicus. Ocular involvement, around 30 to 78% of patients with herpes zoster ophthalmicus. We know about Hutchinson's signs, so if you've got involvement of the nasociliary branch of V1, it will give you ocular involvement in 76%, whereas if Hutchinson's sign is negative, then ocular involvement just in 34%. So what's the epidemiology of this? And so we know that it's more common in the elderly, but interestingly, whilst the rate does go up with age, the median age that we saw within a New Zealand population was 65. And so half of the people who were getting this were not actually at the age where they were eligible for publicly funded vaccination within New Zealand. We looked at 869 patients with herpes zoster ophthalmicus over 10 years, so this is the Auckland zoster study. Of those, 20 subjects were aged less than 16 at presentation. They still had just as severe disease as was occurring in older patients, so they were still getting uveitis and around half of them still getting the corneal involvement. Looking specifically at the patients who were under the age of 40 when they presented, so there was 116 patients. 3 of them had HIV, of which 1 of them was undiagnosed HIV. And so whilst in that under 40 age group, you may do a lot of HIV tests that don't yield anything, I still think it's probably worth it to get that 1% of patients who are going to be HIV positive and not know it, because it's so important. So what is the clinical presentation? In this study, we found a median time from rash was about 5 days when they came in. Half of them had lid swelling, 3/4 had conjunctivitis, corneal involvement in half of them, and 11% had disciform keratitis. Uveitis also occurred in half of the patients, and then we also looked at those rarer presentations. So optic neuropathy occurred in 1.7%, and I've made it a rule to actually do an Ishihara first presentation when I see these patients, because it's useful when they come in later and you realise something's not quite right to have had a documented previous colour vision, because you'll often find that colour vision drop is going to occur at the 1 to 2 week point after the onset of the rash. We also found cranial nerve palsies in 3.5% of patients. And again, that's possibly a little bit more frequent than is generally appreciated. So with treatment, we aim to treat with antiviral within 72 hours of the onset of the rash. Half of them are going to need topical steroid for uveitis or keratitis. And if topical steroid is used, it's really important to do a very, very slow taper because recurrence is so common. So aim to taper over 2 to 3 months. I tend to try for 3. 1 in 7 are going to need treatment for high intraocular pressure. In terms of the uveitis, the typical onset is around day 10, days after the onset of the rash. Pressure is frequently elevated, and so if you see a high pressure, you're going to be looking really carefully for cells because you're frequently going to find them. In terms of the day of presentation and the risk of uveitis, if you see these patients too early, if you see them at day 1 after the onset of the rash, only 10% will have uveitis, but 30% will go on to then develop uveitis. So if you see them at day 1 and there's no problems, you've got to see them again. So for patients, unless they have severe symptoms, unless they have significant vision loss or photophobia, I'm seeing them all around that day 8 to 14. Because if I see them at day 8 to 14, 50% of them will have uveitis, and only 6.5%, if they're normal at that point, will go on to later develop uveitis. And so I can do a one-stop view and largely say that's fine. Unless you develop more symptoms, you can go away at that point if they look fine. With uveitis, so the median duration of topical steroid was 59 days. 41% of patients reoccurred on stopping that treatment. So this is a really, really high failure rate of stopping that topical steroid. And you need to be aware of that. We probably need to be treating for more like 90 days, and we need to be warning the patients that there's an increased rate of this flaring up again and that they may be seeing us over and over again. Make sure you've got a good relationship with these patients because you may not get them out of your rooms. In terms of complications, so as we've said, recurrence, 23% overall had recurrence. Of those who needed topical steroid, it was 42% had a recurrence overall. 17% developed a permanent corneal scar. Neurotrophic keratopathy occurred in 6% of these patients, band keratopathy in 1.5%. We had corneal melts in 2.5%, and we had corneal perforations in 5 patients, so 0.6% of this group. Some of the patients got acute retinal necrosis or panuveitis, usually a couple of weeks down the track following on from that rash. Glaucoma in 3.8%, and then this is the really big thing, vision loss to 6/15 or worse. 20% of patients had that, but these are elderly patients. There was a lot of stuff that was reversible, like cataract. There was a lot of stuff that wasn't anything related to the zoster, like ARMD, like vein occlusions. So if you look at the irreversible vision loss, so not counting cataract, due to herpes zoster, that's about 10% of patients had permanent vision loss due to this disease. This is the kind of acute retinal necrosis, and this particular patient was someone who'd been treated with rituximab and then had got a period of profound neutropenia as a side effect of that. He was being treated for CLL, developed herpes zoster ophthalmicus, and then developed acute retinal necrosis. But some of them will have a more subtle presentation. So sometimes you can get an atypical panuveitis with retinitis and or choroiditis occurring in that 1 to 2 week following. And the things that really, normally I'm not having a really close look at the fundus in my zoster patients. The things that are going to prompt me to have a better look are going to be, they're going to tell me they've got floaters. Zoster patients should not have floaters. It's a really good sign to do a really thorough dilated exam. Neurotrophic keratopathy. So we know corneal innervation is really important for your blinking, your tearing, trophic support for your epithelial cells. Herpetic disease is the most common cause of neurotrophic keratitis, both herpes simplex and herpes zoster. And altered innervation can be associated with breakdown of epithelium. These patients can get persistent epithelial defects, corneal ulceration, and melt. We had a look at risk factors for neurotrophic keratopathy within these patients. And so age was a risk factor, and if you look per decade, every decade you went up in age, there was a 29% increase in risk of neurotrophic keratitis. Things that showed us that you had worse disease on the univariate analysis were all associated with higher incidence of neurotrophic keratopathy, particularly the vision and also the uveitis were the main things that were showing us that. And then, of course, recurrence. And every time you had a recurrence, you got a third, again, increased risk of developing neurotrophic keratitis. So preventing those recurrences is really important in looking after our patients. Those patients who had neurotrophic keratitis had a higher rate of vision loss as well. So they got vision loss in 65% of patients with neurotrophic keratitis. Of course, we talked about corneal melt and perforation, and that was much, much higher, again, in patients with neurotrophic keratitis, as we'd expect. So what about cranial nerve palsies? So these are usually occurring within the first couple of weeks following the onset of the rash, and mostly third and sixth nerve involved. 3 patients had multiple cranial nerves involved, and 1 patient had proptosis as well with this. If we look at the recovery, these generally act a little bit like a microvascular nerve palsy. So the median time to recovery, we tend to say 90 days for a microvascular. It was about 135 days for these ones. Most of them did recover, so complete recovery in 76%. A few of them had a little bit of residual defect. And within our series, we couldn't tell any difference in recovery time in those who were treated more aggressively with IVA cyclovir or with oral prednisone compared to those that we just sat back and watched. So relationships may come and go, but herpes is forever. And we saw that recurrences were more common in those who were immunosuppressed, and they were much more common in those who had uveitis at the initial presentation. And some of these patients had a huge number of recurrences over that 10-year follow-up time. Zoster and stroke is something that really interests me, and we've published on our stroke data for this study in AJO this year. So zoster has been reported to increase the incidence of CVA, and that reported incidence seems to vary between 20% and 400% increased. The greatest risk is in the first 4 to 12 months following zoster, and the mechanism seems to be associated with viral infection of the cerebral arteries. And we found 1.6% of our patients had a stroke after zoster. And if you look at the rates, even in the under 40-year-old age group, 0.9% of them had strokes, 40 to 65, 0.7, and then over 65, it was 2.5%. If there was no association with zoster, we would expect the graph to be absolutely flat, showing the hazard, with the same amount of stroke month after month after month. Instead, what we see is we see a real peak around that 2 to 4 month point, and then it tapers off. And if you were treated with a cyclovir within 72 hours of onset of rash, it decreased massively your risk of stroke by about 70%. And so I think there's that real need to get onto a prompt treatment. There was a 2014 survey looking at zoster vaccination and with stroke, and it basically showed that if you had been vaccinated against zoster, you also had a lower risk of stroke when they controlled for other factors. So this has been my resting facial expression for the last 2.5 years as we've had COVID rage around us. And so it's very, very nice to actually get here and be with you all. I'll just briefly talk about other sequelae of zoster. So there's increased depression and suicide, which is associated with post-herpetic neuralgia primarily. But we've got a quality of life study going on this summer looking at what happens to quality of life in patients with zoster. You have an increased rate of heart attack as well. And when I was looking through these 869 patients, and the first 550 I did for myself before I got so sick of zoster I never wanted to see another case and got a junior to help me. But I found a lot of patients coming in around that 2 to 4 month point with confusion and loss of function, and they'd have a brief CT head, they would say no stroke, and then they'd be admitted to a rest home. And I think there's probably a lot more occult cerebral vasculitis than we're really appreciating. So the zoster eye disease study, we've got an arm of this recruiting patients within Auckland with myself and Dr. Jay Meyer. This is a prospective clinical trial looking at whether oral valacyclovir for a year reduces complications of zoster. And so we're using 1 gram a day compared to placebo, but everything has been delayed due to COVID, so you'll have to watch this space for a while yet. Briefly talking about cataract surgery with zoster. So we looked at 57 eyes with previous HZV, uveitis or keratitis and going through cataract surgery. And 2/3 of them have had recurrent episodes of disease prior to the surgery. This was complicated surgery. A lot of the patients need to use vision blue, predominantly due to corneal scarring. There was iris management involved, intraoperative complications in 14%, and only 2 patients afterwards developed cystoid macular edema, so I think that's pretty good for patients with a history of uveitis. But the really interesting thing here was the rate of recurrence following cataract surgery, and we've done this similar study with HSV. You don't get as much recurrence with HSV, but for zoster, 40% of them had a recurrence, and some of them were really severe. So 3 got band keratopathy after the cataract surgery. 1 had a neurotrophic keratitis with persistent epithelial defect. 1 got such severe uveitis they decompensated their cornea, had to have a corneal graft. 1 had a corneal melt and actually ended up enucleated, and 1 was a severe uveitis that actually kind of ate through their zonules and they subluxed that lens. And so of these patients who had recurrences, 12 ended up with worse vision than they did preoperatively. So that's 12% of the overall group and 50% of patients who had recurrent disease. So I make a really big push to try and prevent those recurrences. I want a 12-month period of being quiet before I do the surgery, if I can get it, longer than I do for a normal uveitis patient, and I give them prophylactic acyclovir. Again, we're going to have to wait for ZEDs to see whether what I'm doing is actually working, but I want to get better results for these patients. So just in summary, this is a frequent presentation. It's got really important eye sequelae. Consider an HIV test if you've got patients under the age of 40 years. There's a high rate of recurrence in these patients, particularly if they're immune suppressed and particularly if they had uveitis when they first came in. There's a high rate of vision loss, and be careful in cataract surgery. Even if they've been quiet for a while, you can get quite severe recurrences afterwards and vision loss with it, so consider antiviral prophylaxis. Thank you.
Thank you indeed, Rachel. I think your enthusiasm for this is infectious. So I have a number of questions here. Sorry, come up to the microphone as well if you have a question. This question here from Mark Whiting, wondering about the role for chronic oral treatment. Is there a role in immunocompetent patients for ongoing oral antivirals after primary zoster? And when do you give a further course of oral antivirals, I guess, in immunocompetent and immunosuppressed patients?
Yeah, and this is what the zoster eye disease study is trying to find out, because we really don't know the answer. So in my practice, if someone just has a single episode, I often leave it at that. If they're getting multiple recurrences, I'll often consider offering them antiviral prophylaxis. I'll discuss the pros and cons and the fact that we really don't have the evidence strongly one way or the other, but I feel like it most likely will work. And then sometimes I find that if I'm really struggling with someone's disease, giving a further 2-week treatment dose feels like it sometimes changes the course of that disease. But again, this is very anecdotal, and from looking over a large number of these zoster patients, I feel like it can make a difference, but time will tell in terms of, seeing the research on that.
The next question is a question we get asked commonly by our patients. What's my risk of developing zoster when I come into contact with someone with chickenpox or zoster?
So you cannot get zoster from coming in contact with someone with chickenpox. If you come in contact with someone with either chickenpox or zoster where the lesions haven't scabbed yet, you can get chickenpox from that. And that's particularly a risk if you haven't had chickenpox before, if you're immunosuppressed, if you're pregnant, then you've got that risk. but you're not going to get zoster itself. Zoster, shingles is that reactivation of the chickenpox. So you're safe from that perspective. And if you've already had chickenpox, you don't need to worry.
This is another really common question. This person's asking, why not see the patients a bit later after their original rash? If you see them after 15 to 21 days, won't you pick up more uveitis or eye disease?
Absolutely, but the thing is that you're also going to let the uveitis burn for a period of time, and so you'll be very efficient, but you won't necessarily be doing the best for your patients. So it's just kind of always juggling those things. So I see patients really early if they've got profound photophobia, if they've got decreased vision, or if they've got any neurological sequelae. Otherwise, I just say red eye. That's fine. We don't care about that. Give them some lubricants, and see them at that kind of 8 to 14-day point, because that's got that best chance of picking it up, but not leaving them too long with their uveitis.
Any questions from the audience, or I'll push on with the dialed-in questions.
I've got a quick question, Tony. I just wanted Rachel to clarify. Sorry, these things are always too high. Just to clarify.
Could you stand up, please? Sorry.
I'm going to stand on the step. Okay. All right. So, Rachel, just about the zoster uveitis. You mentioned that we tapered too quickly and mentioned something along the lines of perhaps 3 months is better. So when you were doing the analysis, is it 3 months that people should be aiming for, or what's too quick?
The problem is that obviously the data is a bit confounded, because those patients who do beautifully, tend to get tapered a bit faster, and those patients who grumble on with a few cells tend to be tapered a little bit lower. So, anecdotally, I think 3 months is good. When we run the recurrence data, which I need to get around to publishing, but when we run the recurrence data, we don't find an association with that timing so much and the risk of recurrence, probably because we're trying to taper it according to what we see clinically, and we're roughly getting it the same for everyone, but we're getting it the same but a bit short for everyone because it is so much recurrence. We do get more recurrence and immune suppressed. And the other thing I was really interested to see is, there was a Moorfield study which looked at risk of recurrence and showed that if you treated people with hourly drops, you actually got more recurrence than those who you treated with 4 to 6 times a day. And their theory was that when you were treating them with really frequent steroids, you were kind of letting the virus go a bit rampant, and it was more likely to stick around and stay in your eye. Whereas when we looked at that data for us, we recorded the number of cells and we recorded the frequency of the steroid, and we found that it was the amount of inflammation that you had at the start that was more predictive of those recurrences, and that treating them with hourly drops didn't seem to be increasing the risk of recurrence, even though generally 4 to 6 times a day is fine for them. But if you need it, you can step it up, and you don't have to feel like you're doing a bad thing for your patient in the long term.
Lindell, yeah. Oh, there's one last question. Someone else has asked about management of zoster optic neuritis.
So the issue with zoster optic neuritis, we've got 15 patients with it, and that's the largest series in the literature. And, with these, we're not finding an amazing difference for these patients. Again, with those who are treated with IV, antiviral, and those treated with, steroid. But I would, with the cranial nerves, I feel that we've got a few more. I feel a little bit more confident saying we didn't find a difference. With the optic neuropathy, they're so very variable that I don't really feel comfortable calling it and saying these treatments are not helpful yet. And it has such a profound impact on your vision that I'd probably still be treating them with these things until we really, really know that it's not helping, because I'm just not confident enough with the small numbers. 15 patients is just not enough.
Sorry, one, yeah.
So I think usually for these patients, if they get a penetrating keratoplasty, it's not that first couple of weeks to 3 months that they're getting those recurrences. It's usually later down the track. And so, a little bit like with the cataract surgery, it's not normally that first month, and they're on so much steroid to start with that it actually is covering a lot of things, in terms of that risk of zoster. And so I think that the more important thing is keeping them on that very, very long-term prophylactic dose. That's what's going to help them, because you're really concerned about those recurrences that occur at 9 months, at a year, at 2 years, all those things that are dropping it off, and like with herpes simplex, that's causing such terrible 5-year results for the grafts.
Rachel, thank you very much.
Great,
It's been
thank you.
fantastic. The next and last speaker is Professor Mei-Ling Takani from Lions Eye Institute in Perth, and she is going to talk to us about cytomegalovirus. May, thanks very much.
Tony, topic of your heart. CMV. Thank you all for coming and listening to our talk. We're in competition with the people next door with glaucoma and neuro-ophthalmology. So I'm just going to finish up the session just giving you a very brief overview of cytomegalovirus. A bit of CMV immunology 101. It is the largest of the herpes virus, human herpes virus 5. And amazingly, its prevalence based on immunoglobulin seropositivity varies depending on which part of the world you're from. It is highest in Asia, running at about highest in Africa, running around 90%, and then next in Asia, Southeast Asia, much less if you're in United States. Amazingly, this virus has co-evolved with us for millions and millions of years, and you wonder, why is that? I don't think anyone knows. And it is species specific, meaning a human CMV virus can only infect humans and not an ape or a mouse. And therein lies the problem in trying to find out more immunology about CMV. There are 3 phases of infection when you come across it. You have the acute phase, which stimulates your innate immunity, so your natural killer cells, neutrophils. Then this virus persists, and that's when it starts to replicate in certain cells. And then the last and most important phase is the latent phase, where your adaptive immunity, your T cells, come into play to keep the CMV infection at bay. It is indeed a very clever virus. It has evolved many mechanisms to prevent the immune system from getting rid of it. One of which is this thing called the viral homologue, replicating interleukin 10, which some of you may know helps to dampen down immune responses. It prevents your MHC class 1 and 2 from presenting antigens, and therefore the immune system cannot detect CMV, and many other mechanisms it uses to evade our robust immunity. I would also like to talk about CMV latency. I mean, what does latency mean? And this also applies to the other herpes virus as well. It basically means that the viral genome stays in quiescence, if you like, in selected cells for life. There's restricted gene expression. That means the viral DNA is there, incorporated into our own human DNA, but it's not replicating. However, under the right conditions, it's able to reactivate to full replicative potential. And unlike the other herpes viruses, CMV can infect many kinds of cells. That's what broad cellular tropism means. So as I said, it's species specific, and we have to rely on animal models, largely the mouse model, to get a better insight as to how this virus behaves. The interesting thing is it can infect many types of cells, particularly ones which are CD34 positive. And these cells, the protein is also expressed in vascular endothelial cells. So unlike herpes simplex and varicella zoster, which has tropisms for neural tissue, CMV can infect all sorts of other things like retinal cells and keratinocytes. And latent CMV DNA has been found in brain, lungs, salivary glands, and so forth. Latency for herpes simplex and varicella is not found in, or has not been detected in ocular tissues. So this leads us to talking about CMV anterior uveitis. It's found in immunocompetent patients, and there must be a strong immunological component to this disease entity in that it's not seen in immunocompromised patients. And we do know that CMV latency has been detected in the iris and ciliary body and the DNA in aqueous humor. So it's a curious disease. You see the CMV in healthy adults. So what could possibly cause the trigger? And it's theorized that there must be some form of local immunosuppression which allows this virus, which has been sleeping in our eye, to reactivate. And it's been seen after eye surgery. Prostaglandin use has been reported used in intraocular steroids, interestingly, after use of topical cyclosporin. And it makes me wonder now that we have access to topical cyclosporin in the form of Icurvis, whether we should be a little bit more careful using it in patients with dry eye disease, and certainly has been reported in graft rejection, where the CMV has been found in stromal keratinocytes, as well as the graft endothelial cells. So again, the incidence of this disease entity is more commonly found in Asia, and it accounts for 75% of hypertensive uveitis in Singapore, and the rates drop to 2% in the United States. And this could be a reflection of the higher seroprevalence of CMV exposure in the world. So what are the signs that helps you think that you could be dealing with CMV, anterior uveitis? So firstly, there are healthy patients, tends to be Asian, and you can see these eyes with endotheliitis, and their KPs can be round, coin-shaped, deposited in a line or in a ring. And some of these KPs, if you look closely enough, can have a clear halo around it. I don't know if you can see it on this slide. So if how do I activate this? Yeah, unfortunately, this pointer doesn't quite. So yeah, I've got this pointer. Can anyone see that? You're too far behind. So a central, prominent, almost nodular looking KP and a clear ring around it, almost like an owl's eye type presentation. And these are linear dots and in a ring and with your endotheliitis. There is absent posterior synechiae. Pupil tends to be round, and one telling clue is the raised intraocular pressure, and the pressure tends to be a lot higher in the 40s, 50s, as opposed to, say, herpes uveitis from simplex or VZV. The overall picture, when you're confronted with what kind of herpes uveitis is this, CMV anterior uveitis tends to look less severe, less red, less painful, unless they've got really high pressures. And if you do an endothelial cell count, they're often low compared to the other eye. And most times it's a unilateral condition. So now that we've become more aware of this entity, there's now a paradigm shift in thinking about two syndromes, the Posner-Schlossman syndrome, which for the older ophthalmologists, in textbooks, we're told it's a recurring hypertensive uveitis, minimal inflammation, some atrophic iris changes, and the other syndrome is Fuchs uveitis syndrome, previously called Fuchs heterochromic cyclitis. Again, you see all these changes with iris atrophy, no synechiae. Most times it's unilateral. Stellate KPs. So, and if you see these two, and if you're thinking, could it be PSS or FUS, especially in Asian males, think CMV anterior uveitis. If they're younger, it's more a Posner-Schlossman type presentation. Older age group, it could be a Fuchs uveitis type syndrome. Usually unilateral, but it can be bilateral. And if you're thinking, could this be CMV, you need to do an anterior chamber tap. There are many ways of doing it. You can do it with a patient lying down or sitting by the slit lamp. I would do it, the patient lying down, anesthetized, and I'll use these caps. Once you get some of the fluid out with a tuberculin syringe, I'll cap it. And the important thing, what I do is I tape the plunger so that the person who is transporting the specimen immediately to the path lab doesn't accidentally push the plunger down, and then you lose this precious fluid. So why do we bother to treat this entity? Because they can sometimes have periods of quiescence. And the main thing is you want to reduce their steroid dependency and hence cataract and glaucoma complications. But not only that, with each spike or with each recurrence of anterior uveitis, these patients can have really high intraocular pressures with consequent damage to the optic nerve. And we do know that CMV uveitis, as compared to the other kinds, the other herpetic ones, they tend to get more secondary glaucoma. There are no clear treatment guidelines at the moment. What you have up on the slide comes from the Singapore experience, where high-dose valganciclovir is used initially for the first 3 weeks, and then that is dropped down to 1 tablet twice a day for a long period of time. It requires long-term therapy because once you stop treatment, there's a high relapse rate of about 50%, and it's not without any toxicity. One needs to monitor for immunosuppression, your white cell count, liver, and renal function. I myself personally, I don't use such high doses, and at the moment seem to be getting away with it. But this is the recommendation in the literature. There's also the option now, though not available in Australia, of using ganciclovir gel or eye drops. And there's this Staccato trial, which is looking at efficacy between the oral and drops. I've started using the gel, but I have to get it compounded and made up by the pharmacy, and I use it twice a day instead of the tablet, and it seems to be controlling the CMV anterior uveitis, but they have to be on it for a long period of time. Going to the back of the eye, we have to revisit CMV retinitis. Again, a lot of the immunology comes from the mouse model of AIDS, and these mice are then injected with CMV, and then we see what happens. And remarkably, the clinical picture in these animal models look very similar to the human ones. And as I mentioned, the CD434 plus cells, so they are hematological cells, vascular endothelial cells. They carry latent CMV virus, and you need an activation of your dendritic cells for the CMV to rear its ugly head. And what happens in the back of the eye is that the vascular endothelial cells become infected. It then consequently infects the next door neighbor, which is your pigment epithelial cells, and then you get the retinal necrosis. And there are different mechanisms of these cell death, which is not only due to infection, but from other kinds of program and non-program cell death. We don't see CMV retinitis now that much with HIV since heart treatment was introduced back in 1996. But just as a guide, in case you do see one, the risk is markedly increased if their CD4 count is less than 40 or the CD8 is less than 520. Patients who have had retinopathy before are also at higher risk, largely due to a disrupted blood-retinal barrier. And HIV and CMV can trans-activate each other, so we tend to see more CMV incidence, CMV retinitis in HIV-positive patients as opposed to non-HIV. And this is now the more common presentation seen around the world in patients with hematologic malignancies, ones who are immune suppressed for transplants, autoimmune disease, patients who've undergone bone marrow or hematopoietic stem cell transfusions, and also local steroid treatment with your Osidex implants. So this here shows patients with CMV following bone marrow transplant and was treated accordingly. The scary thing is that half of these patients are asymptomatic. And if they do develop symptoms, usually it's floaters or flashing lights and blind spots, and this is what you look for. There are three manifestations, three kinds of phenotypes. Indolent, where it tends to be more peripheral, granular, and not much blood. Then you've got this pizza pie type fulminant, full thickness, yellow-white lesions, lots of blood. It tends to be sectorial and around blood vessels. And then the last phenotype is the frosted branch. So what is the difference between CMVR in HIV patients and non-HIV patients? In the non-HIV patients, that you can see more vitreous cells. The vascular occlusions and inflammation involving arteries away from the retinitis tends to be more severe, and their CD4 and CD8 counts their levels may be within normal range, and we think it's more a functional derangement that these patients have, which allows CMV to replicate. If you're in any doubt, always do a biopsy, whether it's a vitreous tap, vitreous pars plana, or a retinal biopsy. As often, because these patients are immune suppressed, their lesions can be very atypical. So not only do you send these for PCR, you do serology looking at CMV antigen levels. And here it just shows a myeloma patient who was given intravitreal triamcinolone on the basis that these white lesions were thought to be myeloma, but in fact it was due to CMV. Another 33-year-old Indian with a weak history of a drop in vision in the in the right eye. And this looks like it could be CMV. So TAP, PCR, and it turns out to be toxoplasma in a HIV positive patient. Another useful tip is if you're not sure what that white lesion is, follow the patient, because if it's, let's say, a cotton wool spot, it will disappear. However, over a 3 to 4 week period, this lesion can evolve and then declare itself that you are actually dealing with something more serious. Treatment, intravitreal, use of intravitreal ganciclovir or foscarnet, and I'll use foscarnet in the first instance. And then once the PCR results return, you can then tailor it accordingly. These days, you can get away with a combination of intravitreal ganciclovir plus oral, because valganciclovir has very good bioavailability. Treat the patient until their immune system is restored, to generally use CD4 levels as a guide. Implants are available, though they're very, very prohibitively expensive. There are other newer antivirals in the market, largely in the US, and they're currently used basically in prophylaxis role in stem cell transplants, and they have a different mechanism of action. So there are options available. It's a matter of getting them into the country. And in CMV resistance, there are now T-cell immunotherapy, where these T-cells are taught to recognize CMV, and then you infuse them into the patients, and it actually works, but it's very time-consuming and very expensive. And interestingly, this other drug, leflunomide, which is commonly used to treat patients with rheumatoid arthritis, it has been found to have activity against CMV. So, CMV playing havoc in the eye, definitely. Interesting that it manifests differently in the front of the eye, in the back of the eye, and in fact, in the mouse model that had CMV anterior uveitis induced, and if you immunosuppress that mouse, it then develops your retinitis. The paradigm shift in thinking about Posner-Schlossman and Fuchs uveitis syndrome concept of CMV latency, I think, is very interesting, and how it evades the immune system. And scarily, it loves to stay latent in a broad range of cells. So consequently, our immune system, to control this virus, must be in a constant state of activation, even though it's a low-grade activation. So what impact does this have on our health and our autoimmunity? So that's the thought that I'll leave with you guys at the end of this presentation. Thank you.
So May, thank you very much for a wonderful overview, and thank you also very much for organising the entire symposium. I think we'll all agree that herpes viruses are our favourite viruses. We do have 3 minutes for questions. Back you come, May.
Thank you so much for that talk. Can I ask what your indications are for doing an AC-TAP? Yeah. So do you do it for all hypertensive uveitis, or do you just do it when it gets recurrent and annoying and you really want an answer?
You know what, Rachel, can you repeat that?
So the question is actually from a number of the questioners as well. The question is, in which patients do you do the TAP? When is a TAP indicated? And the other question that's come up commonly here is, when do you do it? Do you have to do it while the patient is active? So who needs a TAP and when do you do it?
Yeah, so if you see all those signs and in Asians, unilateral, raised pressure, and even if you think that could this be anterior CMV, I would tap them all. It would be one. And the other one, if the recurring, annoying, difficult to control patients tap. I mean, in the past, we used to be afraid of tapping the anterior chamber. It's actually quite innocuous and easy to do. So I would tap anyone whom you're even the slightest thought, could this be CMV? And at least in Perth, you'd have to specify a CMV. I don't know about eastern states. If you just put herpes PCL, they won't do CMV. So you have to put herpes simplex, varicella, and CMV on your path form. And it has to go, you have to get a runner to, once you've procured it, it has to go as quickly as possible to your path lab.
Any other questions? Yes.
Mei Ling, okay, up here, Tony, right at the top. Mei Ling, if you're treating CMV keratitis with your ganciclovir gel twice a day, and they have a recurrence, as they so timely do, what's your action? Do you reduce the high dose topical, or do you go for oral?
You can actually increase the frequency. So 4-6 times a day, gel. And then if you still get nowhere, then I would reinstate the oral valganciclovir. They're very expensive drugs, and I can only get them through a teaching hospital, and only after getting permission from a microbiologist, please give me a script for this. So the use of the gel or drops, it's so much more convenient.
Have you been tempted to use leflunomide?
Sorry?
Have you been tempted to use leflunomide if it's so easy to get?
Not yet. Not yet, but because I'm waiting for more information on that.
So I've got it.
But it's so easy to use, isn't it?
Can I just ask, what's the sensitivity of the taps? Is it around sort of 70% or something positive?
Is it me? Am I deaf?
Yeah. So what is the sensitivity of the anterior
pickup?
chamber
And if you
tap?
get a negative tap, but you suspect it clinically, would you go ahead and treat it?
Do a tap when you see cells. Don't do a tap when you don't see cells floating around. So that will increase your yield. So far, my hit rate has been 100%.
What volume do you take out?
I
you
would
need
take
for
as much. I would in a tuberculin syringe, you'll be about 0.1, enough so that your AC doesn't collapse on you. So as much as possible.
When with high pressure, what's the postulated mechanism? Is there a thing called trabeculitis?
Yeah. CMV has been found in trabecular cells. So it causes swelling and then closure of your drain canals. That's an initial, but then you can also have steroid-related high pressures.
So if you've got a steroid responder, and the pressures are still going high, are you able, and it's not coming down with beta blockers or alpha blockers or carbonic anhydrase inhibitors?
Then your good friend, the glaucoma colleague.
So you wouldn't use a prostaglandin at all for fear?
No.
Never.
Some people would though, but if I use prostaglandin, it's only to tide them through until they get their filtration surgery. The jury is still out here. I mean, there are a lot of my colleagues who would use prostaglandins, but I myself would avoid it if I can.
And when do you start looking for masquerade syndromes like organising quantiferon or CT scans of the chest? Do you wait for bilateral disease or?
This is when a very good history is required. So if the risk for TB exposure is low, I don't bother, and the presenting picture can look quite different as well. CMV versus TB uveitis, TB anterior uveitis.
And just one last question from me. This is more for Stephanie. When people have got corneal ulceration and you're using steroid drops, are you comfortable in not using any antibiotic cover, or do you not worry about having an open corneal wound? And
Generally, I don't know. Can you hear me? Yeah, look, generally, if it's herpetic, then no, I don't add an antibiotic prophylactically because I've got them on the treatment that should heal that ulcer. The thing that I worry about in adding the antimicrobial is that, the antibacterial, sorry, is that, patients often have a limited ability to comply with a certain number of drops. And sort of the more things you put on, the less likely it is that the ones that you really want to work are sort of going in properly. So I don't necessarily, I mean, if they have a very large defect, yes, you'd probably do it, but there's no evidence really around the use of prophylactic antibiotics. So it's hard to know, but, large defects and you think it's going to take a while to heal, it's probably, not a bad idea to do it. Something small that you think is going to heal very quickly and they're on the right treatment, probably don't have to.
Sorry. One last question, Linda.
Yeah, no, this is just a really quick comment just about the PCR hit rate with CMV. Just a word of caution that because the CMV is in a lot of ocular cells, if you've actually got a lot of vitreous heme and you do a tap, you actually could get a false positive. So I think that's just something to be aware of.
Thank you. So on closing, I'd like to thank again Mei Ling very much for organising it and all our speakers. Thank you.
And thank you, Tony, for chairing it.
Yeah, thanks, Tony. That's a great last slide. I like